What do a baby's head and a bag valve mask apparatus have in common? They both have pop-off valves. While one may help you not overventilate someone, the other is not so straightforward. The bulging fontanelle is nothing to be messed with. So, what do we do when the soft spot puts you in a tight spot?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. When you were a wee little one, you needed your fontanelles. First, there was the issue of getting your massive cranium through the birth canal. The flexible and elastic sutures between bones made that possible. Secondly, they let your already big head, relative to body size that is, with all due respect to your massive dome, to let your already sizable brain grow even bigger. Your fontanelle was your friend. By the way, fontanelle, E-L or E-L-L-E? I'm glad you asked. The anatomic term is a relatively new one, first coined in the 1500s. The term originated with another meaning, fons, F-O-N-S. Fons in Latin simply means spring, like where water comes from. Most springs are a little hollow in the ground. Fons in Italian and Spanish became fontana, French fontaine, the diminutives being fontanella and fontanelle, still meaning a small hollow, a dip. Fontanelle became the French anatomic term for the hollow, the indentation between muscles. It was only later in the 1540s that it took on the meaning of a hollow or indentation in the skull, with the secondary understanding that there was water in there too. Fontanelle, E-L-L-E, was the original term in French and in English, and later an alternative English spelling turned out to be fontanelle with E-L. So that's a long, strange trip to tell you that either fontanelle, E-L-L-E, is fine, or fontanelle, E-L, is also fine, if you can live with yourself. Okay, enough of that. Let's start with a case. Young Ian is a 4-month-old boy with no medical problems. He was born full term, vaccinated. He's living his best little baby life with his parents and his 2 older siblings. That is, until everyone comes down with the virus that shall not be named. Ian seems okay until Mother notices a bump on his head. He has no fever, no complaints, maybe a little runny nose the day before, but that's it. Concerned, she called her pediatrician, who sent her into the ED to be evaluated. You see Mother and baby, both of them look great. Vital signs are normal. Mother doesn't know if she should be panicking or if all will be well, and she nervously shows you a photo that she took of Ian on Tuesday at 8 a.m. when he was just making some cute little faces at her. It's Wednesday night now, about 7 p.m., so 36 hours later. Tuesday Ian is a happy little chunky monkey who is smiling, and he has a normal head contour. Wednesday evening Ian is, at worst, a little fussy, but he calms to be more of a skeptical baby curmudgeon with a bulging anterior fontanelle. Now what? First, make sure that you're examining the child in an upright position. So the 2-month-old, the 3-month-old, 4-month-old is examined with mother or father holding them upright. The 6-month-old can sit up. Gravity will do its job, and if you examine the child properly, and he's not crying, he's not defecating, he's not vomiting, and you don't see the fontanelle bulging, then you don't have a bulging fontanelle. Crisis averted. let's use this opportunity to talk about sutures along with fontanelles. Starting anterior to posterior, when you're born, you have your metopic suture that runs vertically up and down your frontal bone. What, did you think you came pre-packaged into the world with a nice, unified frontal bone? Nope, you had a right and a left frontal bone separated by the metopic suture. There's usually no trace of the metopic suture in an adult, although as a baby, if you fuse too early, you get metopic synostosis, a type of craniosynostosis that makes the child's frontal head shape look triangular, what some may call trigonocephaly. If you pick that up on exam, you need to get that child a referral to a neurosurgeon. That suture closed too early and it is impeding the development of the frontal lobe. Think of the metopic suture as the continuation of the sagittal suture all the way through the frontal bone. Moving more posteriorly, you have the coronal suture, which runs between the parietal bones and the frontal bones. Where these four bones come together, the two frontal bones and the two parietal bones, they form a diamond-shaped halo called the anterior fontanelle. When we talk about the bulging fontanelle, we're really talking about mostly the anterior fontanelle. There are others that I will explain briefly, but this is all the anatomy that you really need to know. For completeness sake, and truthfully, who knows what can come through those doors, let's talk about the other structures. The lambdoid suture is, shaped like the Greek letter lambda, or an up arrow. Anyway, where the lambdoid suture and the sagittal sutures meet, there is a small posterior fontanelle. It usually doesn't cause trouble, and it often closes by 2 months of age. You also have a few other clinically undetectable fontanelles, 2 sphenoid fontanelles, 2 mastoid fontanelles, but they close early and no one can tell if they're there anyway, so don't even try. The anterior fontanelle, the star of the show, can close at various times. There's a range, but to make it easier, just remember 6 to 18 months. Am I blown away that a 9-month-old doesn't have an anterior fontanelle, but has a normal-looking head and no evidence of craniosynostosis? No. Am I shook that the 18-month-old still has a little bit of a soft spot? Also no. It's a range. We've established that Ian has a fontanelle. Ian's fontanelle is bulging. So now what? A bulging fontanelle is an emergency until proven otherwise, even if the child is well. It's just one of those high-risk, relatively low-frequency conditions that requires our due diligence, and the default is work up and admit. The bulging fontanelle is either a bleed, an infection, a tumor, or a curiosity. Let's dive in. First, is this a bleed? There are various causes of neonatal and young infant intracranial hemorrhage. The most common is intraventricular hemorrhage and periventricular hemorrhage associated with prematurity. The degree is graded 1 through 4. Grade 1, hemorrhage limited to the germinal matrix. Grade 2, IVH without ventricular dilatation. Grade 3, IVH with ventricular dilatation, occupying more than 50% of the ventricle. And grade 4, IVH with intraparenchymal hemorrhage. The biggest risk factor is prematurity and or low birth weight. The vast majority of these will have been diagnosed at birth because the child was symptomatic or caught on screening at birth or within 7 to 10 days, all using ultrasound. So if Ian, who's 4 months old, was born prematurely, regardless of whether he carried a diagnosis of intraventricular hemorrhage, then we should seriously consider that he may have hydrocephalus from debris blocking his CSF outflow. Spontaneous hemorrhage, undiagnosed blood dyscrasia, even non-accidental trauma, all of those things are on the table. ultrasound may be an acceptable screen if this is the most likely cause. Next, is this bulging fontanelle from a tumor? The most common pediatric brain tumors outside of the neonatal and infant period are medulloblastoma, juvenile pilocytic astrocytoma, ependymoma, diffuse intrinsic pontine glioma. Babies can be born with tumors, and the younger the child with a bulging fontanelle, the more that we should consider these. A congenital brain tumor is rare. It accounts for under 2% of pediatric brain tumors and is defined as those presenting within the first 60 days after birth. They're often just not seen on ultrasound at birth, but they subsequently grow and become more troublesome. Many times these babies already have issues at birth, often from teratomas or hamartomas or germinal tumors. Ultrasound would not likely characterize these well. Options include an MRI under sedation as an outpatient or potentially a CT in the ED. Next, we have infection. Enough said. Anyone can get infected with anything, and really this needs to be ruled out in any child, no matter how well he appears. As a review, newborns are at risk for Group B streptococcus, Streptococcus pneumoniae, Listeria monocytogenes, and E. coli. Babies and young children, strep pneumonia, Neisseria meningitidis, H. influenzae, Group B strep, and even M. tuberculosis. And of course, anyone can get any virus, and we shouldn't try differentiating between bacterial and viral meningitis in the hyperacute setting. Which brings me back to our imaging modalities. We need to LP pretty much every baby with a bulging fontanelle. The only way in the ED to know if this is safe, that is, that we're not risking causing herniation, would be CT. CT could show a shift in brain structures, which puts the child at risk for herniation when you drop someone's intracranial pressure suddenly, or it can be due to simply raised CSF pressure. The only way to detect gross abnormalities in the emergency department really reliably is CT. Having said that, herniation is rare from lumbar puncture. Also, many of these patients who herniate have a normal CT, so you can make the argument that there are other options available. Nothing is perfect. You may want to have a careful discussion with the admitting team about what imaging should happen when, and lumbar puncture or not, especially initially, since there are really no right or wrong answers. Ultrasound through an open fontanelle would mostly tell you hydrocephalus or not, and that may be enough to help you feel comfortable with doing that lumbar puncture. MRI is not really a feasible option when time is not on your side, and that may be said for your ultrasound as well, depending on your resources. I will just tell you, for me and for most EDs out there, CTLP all day long, because ain't nobody got time for that. Bleed, tumor, infection. Those are the etiologies for a bulging fontanelle that we own as emergency physicians. But you may CTLP, all looks good, admit for MRI, do lots of stuff, and the bulging fontanelle ends up being because of something else. It could be something ho-hum. For example, there is an association with normal childhood vaccines and an overreactive fontanelle. Again, diagnosis by exclusion. But now we're moving into an interesting category. I say this because, of course, we're interested, but if your workup in the ED is reassuring and you get a bit of a resistance to admit, you can always offer some of the miscellaneous things that need to be considered, like leukemia. It's a thing. leukemia presenting as a bulging fontanelle, or lead poisoning, or a metabolic disorder, or even congestive heart failure. Admittedly, that would be an odd presentation, but then again, we are the masters of the oddball presentation. Ian has a bulging fontanelle. He needs CT and LP. You do them, both are reassuring. He gets admitted, gets an MRI under sedation. That little bump mom was worried about starts to resolve. The only thing that we could use to explain is that virus, who shall not be named, was likely the culprit. There are actually quite a few case reports out now. I see you, girl. So, to summarize, your fontanelle is your friend. It helped you to get here in one piece, and it helps your massive brain grow into the work of art that it is. It's also an early warning sign for what could be hemorrhage, infection, tumor, or something else. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.